This conference will now be recorded.
Hello, everyone. Welcome and thank you for joining us for today's episode of the ACRM Pandemic Webinar Series produced by ACRM and the ACRM Technology Networking Group. It is intended to bring needed information to rehabilitation researchers and providers regarding the use of telehealth during the pandemic. Today's webinar was produced in collaboration with ACRM's Limb Restoration Rehabilitation Networking Group. My name is John Morris. I'm a senior research scientist at Shepherd Center in Atlanta and serve as past co-chair of ACRM's Technology Networking Group. Today's webinar is titled Limb Loss Rehabilitation During the Pandemic, Stakeholder Perspectives on Barriers and Telemedicine, Part 2. It will be presented by Dr. Prateek Grover. Part 1 of this webinar can be accessed via ACRM's webpage for the Pandemic Webinar Series. Before we get started with the presentation, I do want to advise that this meeting is being recorded. I'd like to ask all attendees to keep phones and microphones muted and keep your cameras turned off throughout the presentation. We do expect to have about 15 or 20 minutes available for discussion at the end of the webinar. So if you have questions, please do type them into the chat window in the GoToMeeting environment. And we will address as many of those as we can during the latter part of the hour. And now it is my pleasure to introduce our guest speaker, Dr. Prateek Grover. Dr. Grover is a board-certified PM&R physician, currently faculty at Washington University School of Medicine, and director for the Rehabilitation Institute of St. Louis, Missouri. In addition to completing a PM&R residency at Washington University, Dr. Grover completed a PhD in biomedical engineering and a National Institute of Disability and Rehabilitation Research Fellowship at Marquette University. Additionally, Dr. Grover has a master's in healthcare administration from Missouri State University. Dr. Grover approaches rehabilitation with the adage, alone we go fast, together we go far. Dr. Grover, we look forward to your talk, and I now enthusiastically turn the presentation over to you. Welcome.
Thank you very much, John, for that wonderful introduction. Everybody, welcome to the second part on limb loss rehabilitation during the pandemic. Stakeholder perspectives on barriers and telemedicine. The first part focused a lot on perspectives provided by the physician and the prosthetist. And so this seminar will give a brief introduction on the journey for limb loss for patients, a very brief primer on the regulations around telemedicine during the pandemic, and then turn over to talking about perspectives by therapy, institution, and small businesses. We'll get to meet the contributors as we go along the journey for this presentation. I do not have any financial conflicts of interest. Any non-financial conflicts relate to employment and professional organization affiliations. Conflicts of interest will be disclosed by the presenters, the contributors on their individual slides. So the need for this webinar arose out of the fact that we recognize that rehabilitation services strongly affect outcomes following limb loss. And when we say services, we are talking about infrastructure, but also the stakeholders. We recognize that the COVID-19 pandemic has created additional barriers, not only for the COVID population, but also for the non-COVID population. And the best way to address these barriers is to look at emerging solutions, but also not to forget that stakeholder coordination is a theme from before the pandemic, and it is really important to work on this as well. The goals of the webinar accordingly relate to talking about barriers to care and discussing emerging solutions during the pandemic. The learning objectives are 5. The first one is understanding the patient's rehabilitation journey after limb loss. The second objective focuses on understanding the infrastructural requirements and stakeholder roles in usual care and the barriers that have been created for these folks and for these infrastructural situations by the pandemic. Presenting how telemedicine has the ability to integrate stakeholders and infrastructure and enable participants to actually adapt this information to their local context. So we'll start by talking briefly about the journey with limb loss and difference. This starts with discovery, whether it's a congenital amputation, limb difference, or an acquired limb loss. The first phase is discovery. This is followed by requiring medical care, but at the same time also starting to think about rehabilitation and the need for equipment. Once the acute phase is over, most folks will proceed to receiving and learning how to use mobility and assistive devices. And with the use of this, the journey will continue as a new normal. From a physiatrist perspective, 9 phases have been described by Dr. Eskenazi in an excellent article. This does get a little bit detailed, but I just want to highlight the major themes. So the first 3 stages or phases focus on surgery. The next 3 phases focus essentially on rehabilitation and the prosthesis. And then the last 3 focus on community function. So as you can see, there are some strong parallels between the patient's journey and the physician perception of the journey. However, that is not the only piece. It is very important to think about stakeholders, the care teams. And there are many ways of thinking about this. This slide is by no means comprehensive, but one arbitrary way to think about the care teams is to think about the medical specialties highlighted in green, which is the acute care physicians, the post-acute care physicians like physiatrists, community physicians that could include primary care physicians, also clinicians that may not be physicians but are just as important, the psychologists, therapists, and prosthetists, and then the non-clinical folks who form a vital part of care teams. So the advocacy and social support groups that we heard about a little bit last time in the last webinar, folks helping with work, driving and recreation, and then insurance and regulatory bodies, their role cannot be ignored. So all of these together are stakeholders involved in taking care of people with limb loss and difference. And so one way of integrating the journey of the patient with the clinicians and the non-clinicians is to think about a common stream, which is the health system. So if we consider a person who has a lower limb amputation, it starts oftentimes with going for wound management for a long time before they actually present to the emergency room. Once the amputation happens, oftentimes folks will go over to an inpatient rehab facility to learn how to take care of the leg. They will then go back home, but they will be visiting with the prosthetist and with the physiatrist to evaluate prosthetic candidacy. If they are prosthetic candidates, they may come back to an inpatient rehab facility or do outpatient prosthetic training. And then once that is completed, they will go back to the new normal. But at the same time, they will have periodic follow-ups with physicians, prosthetists, and therapists to make sure that they are progressing the way they need to be progressing. So the health system can actually capture the stakeholder coordination and the patient journey together. And it's one way of thinking about it. So now that we have seen it's a rather long journey, let us think about patient perspectives. What do the patients actually feel? And this small study was very illuminating because it found that patients had concerns about expectations in relation to the rehab service and the prosthetic device, and they had a lot of uncertainty in general, but specifically related to personal challenges and return to normality. And we saw some of the same themes that the clinicians share with the patients. So these are some barriers that we should be focusing on. This graph tends to actually incorporate the flow of the patient and the care team across the health system. And the reason why that arrow is dotted is because there is the possibility of a lot of miscommunication highlighted in the red arrows, as well as folks not following up over time. So it's leaky, in other words. And these are, again, barriers that have existed to care before COVID came along. Now, the pandemic actually affected all phases, or almost all phases, of this journey through limb loss, with limb loss and limb difference. So it is important for us to focus on emerging solutions. So you can see that the arrow in this case is no longer leaky. So one of the focuses is, how do we actually take the health system and make it more robust? The second is, how do we actually improve the coordination between the patient and caregiver, the medical team, the clinical care team, and the non-clinical team? And the reason for changing the color of the arrows to green is to show that these can be facilitated. One of the solutions that has existed before and has received a lot of emphasis is electronic medical records. And I believe it is now time for telemedicine to be the next big solution to actually integrating the ability of stakeholders to communicate with each other and to make the flow through the health stream more efficient and less leaky. So with that, I'm going to talk briefly about telehealth regulations during the pandemic. We all recognize that telehealth services mean services that are not in person but can be provided through various means. This started with the incentive that folks who are most at risk, including older persons and persons with disabilities, should actually have access to care. And there is not clarity on how long this will last. Any services that are deemed by a covered healthcare provider to be possible through telehealth are covered. And this relates not only to COVID-19 conditions, but also non-COVID conditions. HIPAA defines a healthcare provider as a provider of medical services or health services. So this can be a person, it can also be an organization. And as you can see, a lot of disciplines, physicians, nurses, clinics, hospitals, home health aides, therapists, dentists, pharmacists, laboratories, they're all covered under this. So all of these folks are covered under the current HIPAA waiver for utilizing telemedicine. There is often a question about reimbursement. So with the 1135 waiver, Medicare states that they actually are going to be paying for office, hospital, and other visits. This started back in March of 2020. And just to highlight again, it's a range of providers that includes clinical social workers as well. How do we provide telemedicine? So public-facing products, these are the ones where you can actually have multiple people on at the same time, are not acceptable. Non-public facing remote communication products, on the other hand, and these include platforms such as Apple FaceTime, Facebook Messenger, Google Hangouts, WhatsApp, Zoom, and Skype, are acceptable. Texting applications are acceptable as well. There is a higher level, which is the HIPAA Business Associate Agreements. These are basically agreements that have been taken forward with HIPAA compliance. However, they are not mandatory. So the question really becomes, if we want to provide telemedicine, are we incurring liability? And so OCR says that they will not impose any penalties against covered healthcare providers as long as there is good faith provision of telehealth services. So that should give us confidence as providers, as clinicians, as non-clinicians working with limb loss, that we have the ability to really do good for this patient population, and we will not be penalized in case there are violations that were not intended. So with that, I'm going to turn over to perspectives. We'll start with the therapy perspective, then talk about institutional inpatient rehab perspective, and then at that point, talk a little bit about the small business perspective. So the physical therapy perspective is provided by Kristen Reeves. She's a program manager for limb loss at the Tear Memorial Hermann Hospital, and her work extends beyond administration to clinical and advocacy as well. So telehealth PT has a number of terms that can be used to describe it, but essentially it is the provision of physical therapy that is not provided in person. there is a strong case to be made for telehealth PT. So let us take the example of low back pain interventions. Self-management, psychosocial interventions, and therapeutic exercise have been proven efficacious, and a lot of this can be done through telehealth. There is a high level of agreement between in-clinic diagnosis and diagnosis remotely using a movement screen. And then when it comes to actually looking at how effective therapy is, it was revealed that for upper extremity motor control post-stroke, telehealth therapy was really effective. So there is a strong case to be made for telehealth therapy. However, there have been barriers. The first barrier during the pandemic is patient risk as evaluated by the patient and by the therapists. So somebody who's got more comorbidities, has immunocompromised situation and is older, should they be brought in actually into the clinic, or should this be done by telemedicine? Institutional policies also dictate the utilization of physical therapy. So if there is not sufficient PPE, and if there are policies that need to be made, that delays the institution of in-person therapy, but also telemedicine as resources are diverted to this. And then finally, there is the question of practice. So patients may be afraid of inpatient or in-person therapy, but at the same time may not be as comfortable with actually coming and utilizing technology. So some of the other barriers to physical therapy telehealth include billing, and the key point raised is that it is a really fluid environment, which means that information is changing constantly, which means that if not kept in constant touch and not understood properly, one can be out of compliance. And then of course there is the question of infrastructure. Is the therapy center set up, and is the patient actually set up to be able to do telehealth? In spite of all of these challenges, telehealth for physical therapy is valuable and it is starting up. The indications specifically for limb loss can relate to post-hospitalization care. So for instance, if somebody has an amputation, they require pre-prosthetic rehabilitation. And after pre-prosthetic rehabilitation, they get discharged home. That would be the time for physical therapy evaluation to make sure that they're actually doing the things they need to be doing. It could also be some of the older patients or established patients for whom there is a review that is ongoing. And so let us look at some of the advantages here. It can allow therapy for patients with limited mobility, who would not have done a whole lot in person. It allows for therapy for folks with limited access who may not have access to specialized therapy for limb loss. It does allow for skin checks. It allows for identification of additional care needs. There is a strong motivational aspect to prevent any regression. And then finally, one of the arguments that I think is an important one that we'll see later in the presentation as well, that it actually permits therapy to provide billable care. So from a physical therapy perspective, telehealth is extremely valuable. From an occupational therapy perspective, this is provided by Dr. Debbie Latour, who has multiple perspectives, not only as a clinician, but also as a user of an upper extremity prosthetic, as an educator in a university, and as a consultant for multiple companies that she shares here. She also wanted us to include her email so that if anybody wants to reach out to her, please feel free to do so. She's got a breadth of experience that she'd be happy to share with you. So before the COVID-19 pandemic, telehealth existed, but it was not as used as it could potentially be. And so Kason in 2015 had a strong call to OT action, where he talked about embracing telehealth to keep up with changing healthcare systems and to ensure comprehensive OT availability, while at the same time building evidence that this actually was useful. Some of the challenges to provision of telehealth before COVID-19 were that there were many assumptions, and there was a lack of understanding regarding privacy and security, to name a few other issues. There was a challenge with access, and this limited technology adoption. And there was a challenge with acceptance, related in some part to reimbursement. There are also several themes that are ethical in nature that relate to the provision of telehealth that have been raised. So it is important that telehealth be based upon the principles of access, equitable treatment, fairness in costs, and it is important to consider the technological influence on client relationships as well as quality of life. And then there is a strong emphasis that just like any other therapy that is provided, it should not be profit oriented, it should not be self-serving, and it should not be misrepresentative. And this has been echoed strongly by the American Occupational Therapy Association, both as advisory opinion for telehealth and in their code of ethics. So moving forward to the time which is now, which is during the pandemic, obviously telehealth has received the impetus that it has probably needed for some time. And a variety of telehealth services can be provided in the realm of occupational therapy, from consultation to evaluation, intervention, monitoring client needs, interprofessional collaborations, and education. Telehealth can be provided in different ways. So video conferencing is the most obvious. It can also be accessed on phone through apps. There can be remote monitoring performed, such as with sensors for blood pressure and things of that nature. And there is also the store and forward option. However, telemedicine or telehealth, as we recognize, is not a substitute at all points. And I think this is where the in-person visits become really important, depending obviously upon individual needs and preferences, but especially when you need sensory diagnostic intervention, and there are interventions that require sensory inclusion. And then for modification of assistive devices as well, in-person visits are needed. So now that we can fast forward from the beginning of the pandemic to somewhere hopefully in the middle, the question really is, what is the role of telehealth? Do we really know what it will actually look like? So before COVID-19, we talked about barriers that included assumptions, lack of understanding, access, and acceptance. And if you think about the current situation, there is greater awareness, there is improved access, there is informed experience, and there is more acceptance. And how has this happened? A lot of this has been modeled by the 3E model, which focuses on health behavior change. And the focus has been to educate. So once patients as well as therapists know more about telehealth, then they can be more engaged in trying to actually do this. And once they're able to do it well, then they are empowered to use this more and more. And so issues like fear, privacy and security, reimbursement, resources, and technology still do exist, but their impact over time is gradually being decreased. So just like for physical therapy, we can see that for occupational therapy as well, telemedicine or telehealth is actually very, very useful. Now let us switch gears and talk a little bit about the impact of the pandemic on institutions in rehabilitation. So I'd like to introduce Dr. Lisa Charbonneau and Mark Dwyer. Dr. Lisa Charbonneau is the medical director for Encompass Health, which is an organization comprised of over 130 inpatient rehab facilities and home health and hospice. And among the inpatient rehab facilities, there are the non-academic and then there are the academic kind. And so the Rehab Institute of St. Louis is actually a partnership between Encompass Health and an academic institution, the Barnes-Jewish Corporation, Washington University School of Medicine, and Mark Dwyer is the CEO of the Rehab Institute. And so health system priorities during the pandemic have basically focused on balancing two things. The first is safety of patients, of providers, and staff. And the counterbalance has been the need to sustain with utilization of resources directed towards COVID, with concerns regarding staffing, and with concerns regarding patient volumes. So the major system impact of COVID started out with the need to provide care for three distinct populations: the COVID population, the post-COVID population, which really are folks who have had severe COVID-related morbidity and now require inpatient rehab, and they're extremely deconditioned and can have other medical conditions as well. And then a third category, the folks who have not been affected by COVID. And so a lot of resources have gone towards defining the care that is needed for these three populations and the protocols. And that has been a major impact in the system. The other system impact has actually related to a decrease in number of admissions overall, and this started with stay-at-home and patient concerns, also with cancel elective procedures. So somebody who had a wound who would have been probably ready for surgery, his surgery was deemed quote-unquote elective, and the surgery was delayed. And then finally, lower staffing. So there have been lower admission volumes overall. The other thing that has happened in some places across the country has been that admissions from home and skilled nursing facilities have been restricted to inpatient rehab facilities. And then this is related primarily to the fact that a number of patients in inpatient rehab facilities are medically complex. So it's important to protect them from infection. At the same time, it is important to protect people coming from home from being in a high-risk environment if things can be deferred for a little bit of time. So what has been the impact specifically for the limb loss population? So if you look at the graph on the left-hand side, on the y-axis is the number of discharges, and on the x-axis you can see the months from January to May 2020. And you can see that the numbers were steadily increasing in that first quarter, and then they plummeted greatly over the last 2 months, and social isolation and an increase in the number of COVID cases has been seen. So that just tells us that the number of people who actually were getting care, that number has decreased in the inpatient rehab setting. Now, if you look specifically at the Rehab Institute, which is the table on the right, you can see a small part of the Encompass health system. So about 13 admits a month from 2017 to 2019. Quarter one was similar, a little bit of a drop, but you can see in April, there was a drastic drop. So the number of patients flowing through the St. Louis area in the BJC system also reduced significantly. Congress has responded very strongly to trying to help health systems take care of COVID-19. Started with the Supplemental Appropriations Act, where a lot of funding was provided, and then a number of CMS waivers were offered as well that allowed inpatient rehab facilities to take care of COVID, post-COVID, and non-COVID patients. One of these waivers included telemedicine. And so if we think about the strategy that has been used in Encompass, and this is one example of a big organization, I'm sure there are others, but this is the one I'm familiar with. So they have stressed the use of telemedicine in inpatient rehab facilities in compliance with guidance from the government. At the same time, they have also tried to have patients and providers maintain as much of a face-to-face contact as possible, because ultimately care also determines upon the patient-physician relationship. And so it's been interesting in the system to find that the people who have used telemedicine the most among healthcare providers have not been physicians, they've actually been psychologists. And this makes sense because psychologists can actually have a pretty detailed conversation and address a number of things over telemedicine. The organization has also made sure to provide devices to its institutions as well as recommended platforms. The intent has been to maintain physician staffing, especially for folks who are immunocompromised, while at the same time reducing exposure, occurrence, and time for staff and patients. A number of decisions have been required in implementing telemedicine in the institutional setting. The biggest question obviously is the hardware and the expenses related to that. The second question is the software and the need to maintain HIPAA as much as possible, even though we recognize that there are relaxations. The third question relates to staffing. If somebody is sitting remotely and working with patients, who's the one who's actually carrying the device around? So staffing becomes a question. And then finally, the patient perception. Are they okay with it? Or do they feel that they need to see a physician in person? So these were some of the decision points that have been utilized to actually develop pretty detailed telemedicine protocols in various settings. Telemedicine even though we think about medicine, there is a big role for virtual communication in the inpatient rehab settings, which has been utilized to a great extent to facilitate patient-centric care, which is this figure on the right. Virtual communication facilitates great collaboration, not just between the patient and the clinician, but also between clinical, caregiver, training, and administrative teams. And some great examples are resident education, staff conferences, care managers interacting with patients, rehabilitation counselors that we talked about, and then patients being able to interact with their family and friends. So I think from an institutional perspective, there is a very strong impetus to continue to utilize virtual communication means because it just opens up channels and allows for providing better care. Now we'll switch from the institutional perspective to the O&P small business perspective. And this is shared by Jim Weber, who is the CEO of a small O&P company, but also the immediate past president of the American Orthotic and Prosthetic Association. So his perspective is not just that of his own small business, but it is also perspective that is shared through the means of a survey conducted by AOPA from multiple small businesses with a sample size of about 100. So this survey comes from the mid of May. And if we just look at this one is looking at considering the COVID pandemic, which responses best describe the current status of the business. And so if you look right at the bottom, about 6% of businesses are completely closed. About 13% are open and fully staffed, but a majority actually lie somewhere in between. From the patient perspective, about 55% of patients are scheduling appointments and showing up, which means that 45% may not be, even after scheduling appointments, which is huge. 75% are not scheduling and not showing up. So about 25% patients are missing in that category. And then finally, from a continuum of care perspective, what patients are finding is that about 60% are not able to get appointments with physicians. About 50% are not receiving the prosthetic scripts that they need. 80% of the patients feel that the continuum that we just talked about is disrupted, and only about 20% patients actually feel that they're receiving good O&P services in their community. So the impact is rather significant. And we recognize that telehealth is useful. However, less than 50% people are actually using telehealth. And why is this? So there are a number of causes that have been described. The first one is that it is a non-billable event. So the services provided are associated with the provision of a device. There are documentation barriers, which means that while certain services are covered by waivers, there are a number of services that require in-person visits and require detailed documentation. And then finally, there are disparities in patient populations, which means that not all patients are able to access and use technology as well as some of the other folks can. So these are the major challenges for telehealth for the O&P profession. AOPA is advocating for the ability to provide services through their L-code reimbursement system, which requests that they should be able to get reimbursed for assessments, patient education, and device troubleshooting, all of which are vital for patient care. We recognize that at a certain point, telemedicine services and telehealth services may not be available. So now is the time, as per the O&P profession, to actually focus on making sure that a multidisciplinary team approach is stressed, where all stakeholders work together, utilizing telemedicine to actually prove how useful it is so that it does not go away and it continues to maintain a good role in provision of expert, time, and cost-effective care. With that, I would like to bring it back home. So I would like to gratefully acknowledge American Congress of Rehab Medicine for hosting the Limb Restoration Rehab Networking Group. It is only through this group that it has been possible for me to meet with such wonderful people who have been contributors to this webinar and to be able to get all the diverse perspectives. So talking a little bit about the group itself, it's a rather long name, so we have thought multiple times about changing it, but we have decided that what it stands for requires it to stay. So the term limb restoration actually moves the focus from anatomic limb loss to holistic restoration of the person. And the rehab networking group term draws attention to rehabilitation, which really draws attention to collaboration between all stakeholders involved in rehabilitation with limb loss. The mission statement of the group is to provide opportunities for interdisciplinary collaboration in the field of limb loss rehab in 4 major domains: clinical care, research, advocacy, and patient resources. And the vision relates directly to the task forces. So the first piece of the vision is evidence-based practice independent of the healthcare system. So it does not matter if a patient is living in rural America or has access to the most modern facilities. It should not matter if the patient has insurance or has excellent insurance at the VA or has no insurance. And so how do we do that? One of the major focuses for this group as part of the vision is that professionals in PM&R and primary care and other specialties should actually understand this field well enough to be able to make sure that they are able to provide good care. And so the instructional curriculum task force is focused on an instructional course that actually disseminates this information. The second piece of the vision is interdisciplinary collaborative research opportunities that are addressed by the Implementation Research Task Force. The focus of research here is research with direct clinical impact. And then finally, the third piece is maximizing access and knowledge for persons with limb loss. And the Patient Resources and Advocacy Task Force is focused on this. Ultimately, the LRRNG is designed as a collaborative platform for stakeholders that lies on a spectrum centered around people with limb loss and difference. So we are grateful, extremely grateful to the technology group for actually hosting this webinar. There have been some excellent collaborations with the international group, based upon which there are actually some studies going on in Latin America where I have had the opportunity to collaborate with folks from Latin America. We had the opportunity to actually present a webinar on a seminar, a symposium on pain, phantom pain, last year in collaboration with the Pain Networking Group. The LRRNG is also focused strongly on collaboration with professional associations, including Amputee Coalition and American Orthotic and Prosthetic Association, and also supports research and policy initiatives such as the National Limb Loss Registry. Ultimately, what we want to do, and I'm sure we want to do this as a community, is support all stakeholder perspectives so that all of us are able to, together as a team, provide the care that the patients with limb loss and difference need, utilizing strong collaborative measures and tools such as electronic medical records and telemedicine and telehealth at this point. I would like to acknowledge the contributors from part 1, Denise Hoffman from Freedom Innovations, John Felder from WashU, Tony Sparling from Harvard School of Medicine, and Kirk Pills from Hanger. And with that, I would like to thank everybody for their attention, and I'm happy to take any questions.
Excellent. Thanks so much, Dr. Grover. That really interesting and informative and passionate presentation, and thank you for that. I remind the audience that we do have time for questions and answers, and I have a few to ask, but please, if you have some, post those in the chat window in the GoToMeeting environment. And so, Dr. Grover, I know we talked about this a little bit last time about the uncertainty of the journey for the patient. It's long, there's multiple providers, and there's a lot to do and a lot to know for the patients. And so I'm wondering, since a month has passed since you provided part one of this webinar, and I guess you had some experience with telehealth in the pandemic, era. And I'm wondering if perhaps the telehealth has maybe increased the uncertainty on the part of the need to use telehealth has increased the uncertainty on the part of the patient, or maybe not so much, or maybe there just is not evidence yet. I wonder if you could comment on that.
So that is an excellent question. That is an excellent question, John. Telehealth is still, I believe, in its infancy as far as implementation is concerned, and I think it is being used at different levels across the country, depending upon the incidence of COVID in that area. So there are certain areas where telemedicine has got rather limited application. There are other areas which are more affected where telemedicine is being used far more. In our system, which is in St. Louis, which I would say has got moderate community spread of COVID, and we are beginning to see a little bit more control, knock on wood. Telemedicine is gradually getting used more. There are growing challenges. I think the biggest challenge that patients have is technology. It is, how do we actually get this set up? How do we use it? And the other piece is communication. So I think there is, because there is such a long chain that has to be linked between the provider and the patient by the administrative staff and by the technologists. Just like we saw with the continuum of care, where there are holes, I think there are holes. And I think that to some extent is certainly increasing the uncertainty. Now, the hope is that over the next few weeks to months, we are able to solidify the implementation of the system better, and that may actually be very helpful in actually bridging all of these holes and making sure that we are proceeding forward. I'm certainly beginning to see my clinic volumes grow, which is a good sign.
Excellent, excellent. Well, regarding the PT perspective by your colleague Kristen Reeves, some research was listed related to the benefits of PT via telehealth, and including that it can be as effective in clinic therapy for upper extremity motor control post-CVA. It has a high level of agreement between in-clinic and telehealth PT diagnosis using functional movement screen. And the most effective interventions for lower back pain are patient self-management, psychosocial interventions, and therapeutic exercise. But I'm wondering then, specifically for people with limb loss, are there distinct aspects of PT for this population for which telehealth can be especially effective, but also conversely very challenging or difficult?
So two parts to the question. The first part, I guess, is what are the applications specifically for limb loss with telehealth PT? And then I think the other question is what are the challenges and where can telehealth PT not be useful? So to answer the first one, I think the biggest role that telehealth PT has is encouraging activity. And we saw this from the patient perspective in the last webinar. That activity levels strongly go down when people are at home. So telehealth PT could encourage activities specifically for people who may be Medicare K1 level and so on and so forth, but also for other folks who are K2 and K3s. The other role that I think is really important is monitoring the limb, which dictates for a lot of folks the ability to use a prosthetic device, or if they are folks with new limb loss, the ability to actually get a new prosthetic device. As far as challenges are concerned, I think the biggest challenge with telehealth is for physical therapy specifically is that things like gait training with the new prosthetic device cannot be done by telehealth. Things like balance training cannot be done with telehealth. Anything that requires sensory input cannot be done by telehealth. So I think it's a fine balance, but just like any new technology, even though telehealth is not new, I think the stress on figuring out the role of telehealth is relatively newer. And so I think, as with any other technology, it is really important for us to continue thinking and expanding ways of utilizing this to continue to provide care.
Great. Well, that leads into the next question about this idea that among, perhaps maybe it's overblown among PTs, that if I'm not putting my hands on the patient, it's not PT. And again, that might be more of a urban myth than reality. But I guess the question is then, other new technologies or emerging technologies that could sort of overcome that sort of distance factor. You just sort of alluded to, and identified some of the limitations of telehealth, but things like monitoring, wearable sensors for remote patient monitoring. Are there opportunities there, or are you hopeful that the realm of interventions that can be delivered via telehealth may expand as technology expands?
So the answer to that, the short answer to that is yes. To elaborate on that a little more, I've actually been contacted by a few companies who focus on offering telehealth occupational and physical therapy. And they actually have exactly the same thing that you mentioned, John, which is actually using sensors. Now, their applications are not specific to limb loss, but they're more orthopedic geared, where the patients actually have less, I would say, less amount of training or less amount of newer training that is needed. But there is certainly a big role in monitoring using sensors. We recognize that in folks with limb loss, when we start rehabilitation, it can be a time when their physiologic parameters can fluctuate. So the sugars can fluctuate. We recognize the blood pressure can fluctuate. We recognize that they are at risk of arrhythmias and things of that nature, just by the amount of activity they put in if they are higher level amputations. And therefore, there is a strong role of using sensors. And I think it really comes down to the stage of the journey. At which stage are they? And I think there is a very strong role for doing therapy once they already know how to walk but require further therapy. Or there may be folks who have actually been using prosthetic devices for some time but are now deconditioned and require therapy. So I think it's going to go back to patient selection initially to define very clearly where telehealth is useful. And in that application of telehealth, sensors would play a great role.
Super, thanks. And so both the PT and OT perspectives presented here noted that similar challenges to using telehealth for limb loss and restoration, and those included, basically technology, including the patient's computer and phone access, connectivity issues, limited equipment at home, etc. And I'm wondering, are there ways for or workarounds to overcome these challenges of the sort of technology environment on the patient side?
So I think Dr. Latour's health behavior change model, the 3E model, educate, engage, and empower, I think is a great model to use for increasing the utilization of telehealth by patients as well as by providers. I think as far as the use of telehealth is concerned, it has to start with patient education. So there has to be a strong focus, and I think a lot of health systems are actually doing this, is that they are utilizing a lot of administrative staff to call the patients, to make sure that they understand the system, providing written instructions. The one thing that would be useful would be to test it. And I think in some disciplines, it is probably easier to test it given the number of interactions that they are required to have, where a whole visit could probably just be devoted to calling a person, making sure they're able to get it set up, and then continue working on it. So I think that health behavior model with the 3 E's, which starts with education, goes to engagement, where the patients and the therapists now are beginning to be more interested in it, and then goes to empowerment, where they actually start using it robustly, is the way forward.
Super. And you noted that obviously telehealth has a lot of potential for rehabilitation, and particularly for the population that you serve. And I'm wondering, as we get used to the pandemic or get somehow past it in some way, and we return to sort of what we might regard as normal operations, are there aspects of telehealth for people with limb loss that likely will not go back to an in-clinic setting, and may be more likely to be delivered more often via telehealth?
So I think that is the hope for all the stakeholders in general, is that telehealth continues to stay relevant and stay prominent in the care of folks with limb loss going forward. We recognize that certain services cannot be offered by telehealth. Gait training is a great example, right? Admission to inpatient rehab obviously cannot be offered by telehealth. Surgeries cannot be offered by telehealth. But a lot of the follow-up, some of the therapy, a lot of the education, a lot of the communication between stakeholders, between the physician, the prosthetist, the therapist, the patient, the caregiver, maybe even insurance companies, a lot of this actually can be enabled and facilitated by virtual communication. So the hope and the movement right now is to study telehealth and study the impact of telehealth on provision of care, which is one of my personal goals as well, is to see how my clinical practice actually gets impacted by utilization of telehealth, and am I actually able to provide better services by better coordination. So the hope is that telehealth stays, and there's a lot of work ongoing to make sure that it does as well.
Super. And I did want to spend a little bit of time talking about the small business perspective. We all know that the pandemic has caused a terrible economic impact and considerable displacement. And the limb loss and restoration service, constellation or industry often includes small businesses, and you showed data that indicated quite a considerable economic impact. I'm wondering, what's the prospect? Are we at risk of losing what we might call installed capacity to deliver services to people with limb loss? And how long will it take to rebuild any possible sort of loss of provision of services? Dr. Grover. I believe we have lost Dr. Grover. There he is.
John, can you hear me?
Yes.
Okay. Well, apologies. I think we got cut off for a minute there. So I think that is the question that the country is asking in general at this point. The question really is, are we going to sustain? And if we sustain, are there going to be challenges in sustaining? And the answer to that is yes. Across the country, in all the disciplines, everybody's asking the same question. Surgical volumes are down. Institutional volumes are down. There are pay cuts across. From a small business perspective, there is the danger that a number of small businesses will go under. So what can be done for that? I think organizations like the American Orthotic and Prosthetic Association are starting out with surveys to understand the ground situation and advocacy to make sure that businesses continue to stay. I think there will be a little bit of a downturn, but I think over time, if everybody works together as a team and proves that there is value, which undeniably there is, but proves that there is value in working together as a team that impacts patient care directly and actually provides better patient outcomes. And telemedicine or telehealth is one way to do it. I think that is the argument to be made, to try and make sure that we do not lose capacity over time.
Super. Well, we have a couple minutes left. I might ask one last question, and that is about the institutional perspective. In your presentation, it was noted that virtual communications among providers offer a number of benefits to delivering efficient and effective care. But at the same time, we've seen numerous sort of commentary and news reports about the sort of, if you will, the psychological and mental fatigue of these numerous, teleconferences that we're all on these days. And I'm wondering, is there a limit to the number of sort of teleconferences that an individual provider can engage in during a day? And have you seen some of that fatigue, if you will, that sort of telehealth or teleconference fatigue among you or your colleagues?
There is certainly a fatigue component. There is absolutely no doubt about the fact that sitting in front of a screen and trying to interact with people, sometimes over video conference, but many times over just phone, does not allow you to get a complete picture. And I think it takes a little bit away from that provider-patient interaction. From just a general communication perspective, I've heard from multiple colleagues that they would like to get back to sitting down in the same room and even having routine meetings in person. So there is fatigue, but I think there is also the recognition and understanding that things evolve, healthcare evolves, and as it does, we need to be able to work along with the changes to make sure that we are able to provide the care that is needed. I think as things hopefully with the pandemic become better, I think there will be a gradual reopening, and I think there will be a combination of services provided in medicine that are divided between in-person and telemedicine. While there is the danger of fatigue right now, I think there is also the real danger of losing telehealth, which I think we need to balance. So people recognize the benefits of telemedicine. People recognize that there is fatigue. Many institutions actually have resources to work with that fatigue as well. But I think together as a field, we are seeing a sea change here, and I think continuing to work with each other, continuing to support each other, and continuing to provide the care that the patients need in this time is the need of the hour.
Excellent. Well, thank you, Dr. Grover, for the very interesting discussion and informative presentation, and for taking your time to share your knowledge and experiences with us. This concludes our webinar for today. Audience members, please note that you will be able to access a recording of this webinar within 48 hours on the ACRM website. And with that, I thank you for attending, and I thank you, Dr. Grover, for sharing your thoughts with us today. Good day.
I want to take this opportunity to thank John and to thank ACRM and the Technology Networking Group as well for this amazing opportunity to be able to share some of my thoughts and the thoughts of all the contributors. So thank you, everybody, and have a great week.
Thank you, Dr. Grover. Bye.